Hello everybody, Assalamu alaikum. Today I'm going to be discussing the very important topic of embryology, which is the development of the respiratory system. So we're going to discuss this topic from the beginning of the formation of the respiratory diverticulum till the lung maturation process. And also we'll reflect upon some congenital abnormalities. So our learning objectives for today are that you should be able to describe the successive stages involved in the formation of the larynx and trachea from the respiratory diverticulum. Also, you should be able to explain the process of expansion of the lungs into the pericardio-peritoneal canals and formation of the definitive pleural cavity. And you should also be able to describe the successive stages involved in the formation of the bronchial tree and elaborate with the help of diagrams the stages involved in histological and functional maturation of the lungs. Regarding the clinical correlation, we'll talk about esophageal atresia and tracheoesophageal fistulae, and also we shall describe the etiology, pathogenesis, and clinical manifestations as well as treatment of the infantile respiratory distress syndrome. So starting with the development of respiratory system, the story begins with the appearance of a sac-like evagination from the floor of the pharynx in the 4th week of development, which is known as the respiratory diverticulum or primordium. So initially, a groove appears in the floor of the caudal part of the primordial pharynx. This groove is called the laryngotracheal groove. And from this groove, by the end of the 4th week of development, there is an evagination and a pouch-like sac forms, which is the respiratory diverticulum. And we can loosely call it the lung bud, but the better term for it right now, this stage of development is respiratory primordium. So here, let's look at these diagrams. And in the diagram A, you can see the sagittal view. If you follow the laser pointer over here, I am pointing towards the yellow region, which is the primitive gut tube. Now, the upper part of this primitive gut tube, which is known as the foregut, you can see over here the blue evagination or sac-like pouch, which has appeared from the foregut, has been labeled as respiratory diverticulum. So this appears in the 4th week of development. And the uppermost part of foregut in diagram B, you can see it has been magnified, and this is the pharyngeal gut, to be more specific. You can see the openings of the pharyngeal pouches. Now, the caudal part of this pharyngeal gut, now we're talking about that. Here, the laryngotracheal groove has appeared from where the sac-like evagination is protruding, known as the respiratory diverticulum. And its communication with the pharynx is known as laryngotracheal orifice. So when this respiratory primordium appears from the foregut, it is separated from the remaining part of the foregut by 2 longitudinal ridges known as tracheoesophageal folds. These folds will move towards each other and will unite or fuse and form a tracheoesophageal septum, completely separating the trachea, which is going to be from the anterior part of the foregut, from the esophagus, which will be derived from the posterior part of the foregut. So the cranial part of foregut is divided into these 2 regions. The ventral part is laryngotracheal tube, which will form larynx and trachea, and dorsal part is the esophagus. Here are the diagrams showing us the splitting of the foregut into the esophagus and trachea. This yellow portion is the foregut, and this blue portion is the respiratory diverticulum appearing from the ventral wall of the foregut. And here are the longitudinal tracheoesophageal ridges, which are in this diagram, you can see approaching each other. And as they unite, they form a septum and they divide the foregut into a posterior esophagus and an anterior trachea. Now, let's talk about the formation of the larynx. The larynx is derived from the cranial end of the laryngotracheal tube. And the internal lining of the larynx, it is endodermal in origin since it is derived from the foregut. Whereas the cartilage and muscles originate from the mesenchyme of 4th and 6th pharyngeal arches. Now here are the coronal sections through the primordial pharynx, showing us the stages involved in the formation of the larynx. And these stages are showing us week 4 of development in diagram A. B shows week 5 of development, C is week 6, and D is week 10. So in the early stages of development, you can see in the lower part of the caudal part of the primordial pharynx, a vertical slit has appeared in the midline, which has been labeled the laryngotracheal groove. And on either side, these are simply the pharyngeal arches. In the next stages, you can see that on either side of this vertical slit, these two swellings appear known as the arytenoid swellings, and they cause the conversion of this laryngotracheal groove, which is a vertical slit, into a more T-shaped opening, which you can see is better seen in diagram C. Here is the T-shaped opening, which has now been labeled the laryngeal inlet. The laryngeal inlet expands in the further stages of development. Now the development of the trachea. When we talk about that, we know trachea is derived from the caudal part of laryngotracheal tube, and its epithelium and glands are also endodermal in origin, whereas the cartilage, connective tissue, and muscles of the trachea, they are derived from splanchnic mesoderm. So here the diagrams showing us the stages in the formation of the trachea. Initially, it is simply a tube which has an internal layer, which is endodermal, and external layer, which is mesodermal. Then in the further stages of development, the endodermal layer forms the epithelium, and the surrounding mesoderm, it forms the cartilage. Over here, you can see the cartilage and the smooth muscle of the trachea. The smooth muscle is present posteriorly, known as trachealis, and the cartilage is present in the form of the C-shaped ring. Now let's talk about the caudal half of the laryngotracheal tube or the respiratory primordium. This subdivides into two extensions which are labeled as primary bronchial buds. These are going to form the future right and left lungs. Now, the primary bronchial buds, which can be properly called the lung buds, they are going to grow and expand laterally and caudally within the pericardio-peritoneal canals. Now, the pericardio-peritoneal canals, they are passageways which have limited space. As the expansion of lung buds within pericardio-peritoneal canals is very rapid, this space is quickly going to be used up, and this causes the appearance of pleuropericardial folds. Now, to understand in a much better and easier way what I just elaborated, here are the diagrams. The diagram B, which is showing us the early stages in embryonic development. The laser pointer here is focusing on a sheet of mesodermal tissue known as the septum transversum. This is a sheet of mesodermal tissue which divides the primitive thoracic cavity above, or you could say separates the primitive thoracic cavity above from the abdominal cavity below. But posteriorly, if you look over here, the septum transversum is deficient or absent. And these are the passageways or the communication canals between the thoracic cavity above and abdominal cavity below. These passageways or canals are called the pericardio-peritoneal canals. It is within these canals that the primary bronchial buds are going to grow and expand. So if we take a cross section at this level, we can see in diagram C, here are the primary bronchial buds, and they entered these pericardio-peritoneal canals. They are expanding within these canals. So right now the laser pointer is present within this pericardio-peritoneal canal, and it's going to form the future pleural cavity of the lung. Also, you can see the appearance of these folds. One is over here and the other is over here. These are the pleuropericardial folds. These are the folds which are going to separate the primitive thoracic cavity into two parts, which are the pleural cavities, and over here, the pericardial cavity, which is going to surround the developing heart. And within these pleuropericardial folds are present the phrenic nerve and the common cardinal vein. Okay, so now that I've mentioned the pleural cavity, I'm going to carry that further. Pleural cavity, you've just seen that it is derived from the pericardio-peritoneal canals. Now, as lungs develop, there are two layers of the pleura, the visceral pleura and the parietal pleura, which will appear. Visceral pleura is derived from splanchnic mesoderm, whereas the thoracic body wall becomes lined with parietal pleura, which is derived from somatic mesoderm. And the space between these two pleurae is the pleural cavity. This is a small quantity, about 10 to 15 ml of pleural fluid. Here is the diagram A, which is showing you the expansion of the primary bronchial buds within the pleural cavities, which are initially the pericardio-peritoneal canals. And these are the primary bronchial buds for the left and right lungs. And the further budding, we will talk about that is into the lobar buds or the secondary bronchial buds. Here is the layer of visceral pleura, which is lining the lung parenchyma, and here is the external parietal pleura. And in this diagram over here, we can see that the visceral pleura, it is lining the lobes of the lungs, and here we have the parietal pleura, and between them, this here is the pleural cavity. Now, coming to the bronchial tree, like I said, the primary bronchial buds, they are going to further divide and form secondary bronchial or lobar buds. Now, these are 3 for the right lung and 2 for the left. By the 7th week of development, the lobar buds undergo progressive branching into the tertiary or segmental buds, which are 10 in the right and 8 or 9 in the left lung. So each segmental bronchus, remember, with its surrounding lung parenchyma, is going to form the primordium of the bronchopulmonary segment. Now, by the end of the 6th month of intrauterine life, remember, about 17 orders of branches have formed, and the respiratory bronchioles have also developed. An additional 7 orders of airways develop postnatally, meaning after birth. So here is the segmentation. This is the formation of the bronchial tree. You can see in the 4th week of development, these are the secondary bronchial buds or the lobar buds, 2 on the left and 3 on the right. And they are further growing and subdividing, and A, B, C, D, E, these represent the lobar or secondary bronchial buds, and they will further give rise to the tertiary or segmental bronchi within each lobe. So eventually, this is a bronchopulmonary segment. It can be delineated. You can see that within the bronchopulmonary segment, here is the segmental bronchus, and it is accompanied by the branches of the pulmonary artery, whereas in the connective tissue between the bronchopulmonary segments run the pulmonary veins. Also remember that there are many lung lobules within each bronchopulmonary segment, and lung lobule is the part which is supplied by a bronchiole. Okay, now let's come to the discussion of lung maturation. Now, this is a very important topic, so let's just try to focus on this lung maturation, which is subdivided for our better understanding into these 4 stages during intrauterine life. The first is the pseudoglandular period, then comes canalicular period, followed by terminal sac period, and lastly the alveolar period. Now, this table is from Langman's Medical Embryology, and this gives a very concise summary of the stages of lung maturation with the time periods. The first is the pseudoglandular period. Now, this is from the 5th to 16th week of gestation. And in this stage, branching has continued from the bronchi to form terminal bronchioles, but respiratory bronchioles or alveoli are not present. Then comes the canalicular period. Now, in the canalicular period, we have the terminal bronchiole dividing into respiratory bronchioles, which in turn give rise to alveolar ducts. So this time period is from the 16th to 26th week of the intrauterine life. And remember that the 24th weeks would mean the end of the 6 months of development. So when we say 26th week, we are talking about the start of the 7th month of development. Then comes the terminal sac period. Now, terminal sac period is from this 26th week of intrauterine life till birth. This is the time when primitive alveoli have appeared. So they're also known as the terminal sacs, and also the capillaries, they have established close contact with the epithelium. So in this time period, if the fetus is born, the fetus would be able to survive, which is the terminal sac period. Then coming on to the alveolar period, which is from 8th month till childhood. This is the time period when mature alveoli have well-developed epithelial, endothelial, capillary contacts. So this is the time period when the fetus, it is ideal for the fetus that it can survive on its own. In the terminal sac period, although we said the fetus would be able to survive, but it would need support, it would need intensive care and evaluation. So now that we have briefly discussed these stages, let's look a little into the detail of when we're talking about the lung maturation. Diagram A shows us the canalicular period. And like I said, this is from the 16 to 26 week of development. The respiratory bronchioles, you can see in this stage, they are present. So here is the terminal bronchiole, and it is further dividing into these respiratory bronchioles. But the epithelial lining in the respiratory bronchioles is cuboidal epithelium. Also, the capillaries which are surrounding these bronchioles, they are present at a distance from the bronchioles. So survival during this time period, if the fetus is delivered, would be difficult and would need a lot of intensive care and support. Then if we look at the further stage, which is now the terminal sac period, when we talk about the end of the 6th and the beginning of the 7th month, this is now the time period which would also need support, but the situation is definitely, it has improved if you compare it with the canalicular period, because now the terminal sacs, that is, they have made their appearance, the alveoli, and the alveoli have these thin epithelial walls, they have thin epithelial linings, and the capillaries have also established a close contact or communication with these epithelial walls. So gaseous exchange is now possible. And so the prospects of survival, the prognosis would be better at this stage of development if the fetus were to be delivered. Now, when we talk about the survival of the fetus and lung maturation, we have to mention the surfactant. Surfactant is an important substance which is necessary for lung maturation. What is it composed of? It is a combination of lipids and proteins, and the human surfactant which is produced during lung maturation is dipalmitoyl phosphatidylcholine. So that is its lengthy name, the biochemical name, and it is produced by the epithelial cells within the lung parenchyma. That is, to be more specific, the type 2 epithelial cells, which are the cuboidal cells within the lung parenchyma. They are the primary sites of surfactant. And the function is that it is going to reduce surface tension at the air-alveolar interface. So what is surface tension now that I've mentioned it? Surface tension is the, you could say, result of the net inward force experienced by molecules which are present on the surface of a liquid. So here you could see these molecules on the surface of the liquid. The forces between these molecules, they are going to bring them together, and this is the cohesive force. This is known as surface tension. Now, in the lungs, the surface tension is the force which tends to collapse the alveoli. And so the chemical needed and the chemical substance required to lower the surface tension is the surfactant. Now, this surfactant, what it does is that it forms a monomolecular film over the walls of the alveolar sacs, and it counteracts the surface tension at the air-alveolar interface. Surfactant production, remember, begins in the 20th to 22nd week of gestation. And then its levels, they go on rising and they reach their highest in the last 2 weeks of gestation. Now, like I said before, respiration is possible at the end of the canalicular stage. And when we talk about canalicular stage, remember, we are talking about the end of the canalicular stage when respiration might be possible, and a fetus may survive if it is given intensive care. So this is now the last 4th stage of development, which is the terminal sac period. So terminal sac period, when we talk about the terminal sac period, we see that we have, let's just go back to this table over here. The terminal sac period is up till birth, and it coincides with this alveolar period when the mature alveoli have also started to appear. So these stages, they start from the 8th month onwards when the mature alveoli have started to make their appearance. And in this stage, you can see that the capillaries, all these capillaries, they have established a close communication and intimate contact with these epithelial cells, these flattened epithelial cells, which are type 1 epithelial cells or pneumocytes. And now the gaseous exchange is possible. And between them, these cuboidal cells, which are the type 2 pneumocytes, are surfactant-producing cells. So their quantities are also now sufficient to support the survival of the fetus. The lymph capillaries are also present. So the epithelium has become so thin that capillaries, they are bulging into the alveolar sacs. And by 38 weeks, now we're talking about the end of gestation, lungs are capable of respiration because the alveolo-capillary or respiratory membrane is thin enough to allow for gaseous exchange. So when we talk about development of alveoli, remember an important point to keep in mind is that 95% of mature alveoli develop postnatally. So although the mature alveoli have started to make their appearance at the end of gestation, but it is mainly during the childhood years when most of the mature alveoli will develop. And the immature alveoli are those which have the potential of forming additional primordial alveoli, and therefore they can increase the surface area for blood-air interface. And as these immature alveoli increase in size, they become the mature alveoli. There are approximately 150 million primordial alveoli present in the lungs of a full-term neonate. Now, this is 1/2 of the adult number. Because of this, when we look at the chest radiograph of an infant, the lung of the neonate will appear denser than the adult lungs. Then in the childhood years, like I said, between age 3 and 8 years approximately, the adult number of 300 million alveoli will be achieved. Now that we have discussed the maturation of lung, the role of surfactant, we have talked about the basic concepts of respiratory system development. Let's come to the clinical correlation. I would like to start by discussing the esophageal atresia and tracheoesophageal fistulae. Now, if you recall, when we talked about the formation of the trachea, we mentioned that the tracheoesophageal ridges appear in the foregut and they subdivide the foregut or split it into an anterior part, which is trachea, and a posterior part of which is esophagus. If this splitting is incomplete, if this division is incomplete, it can cause the formation of a fistula, which you can see here is an abnormal communication and epithelialized tract present between the esophagus and the trachea. Now, there are different presentations and different types of these tracheoesophageal fistulae. The most common presentation, more than 90% cases, is the one which you are looking at in diagram A, in which the lower or distal part of esophagus is having an abnormal communication, that is a fistula, with the trachea. Whereas the upper part of the esophagus, it is not in communication with the distal part of the esophagus, but is ending as a blind pouch. So this is esophageal atresia. So in more than 90% cases, this is the presentation. This is the type of fistula which is going to form. Now let's look at the less common variants. The less common ones are in diagram B, you can see there is esophageal atresia without a fistula. In diagram C, you can see that the fistula is formed after the union of the upper and lower parts of the esophagus. And here in diagram D, you can see the situation is opposite to that in which you saw in A. Here, the upper or cranial end of the esophagus is forming the fistula, whereas the lower end is ending as the atretic end. And in diagram E, there are two separate fistulae or two separate communications of the esophagus with the trachea. Now, in these different situations, this is a congenital abnormality. And in this condition, what do you think the symptoms would be if there is a fistulous communication with the of the esophagus with the trachea? We see in diagram A, which is the more common one, the upper part of esophagus is atretic. So since the upper part of the esophagus is atretic, this will interfere obviously with the feeding and the swallowing of the neonate. So the neonate will experience drooling of saliva and also regurgitation of milk on feeding. And since the lower part of the esophagus, it is in communication with the trachea, this can cause reflux of gastrointestinal contents, gastroesophageal contents into the trachea, into the respiratory tract, and this then can cause coughing, it can cause breathing problems. And other than these symptoms, when we talk about the complications, we remember the 2 P's. The first P to keep in mind is pneumonitis. So since there is a fistula between the esophagus and trachea, that can cause the pneumonitis. And also we talk about polyhydramnios, that's the other complication. Since the esophagus is atretic and the removal of amniotic fluid by the swallowing mechanism, that is impaired, and this causes an increased amount of amniotic fluid within the amniotic cavity, resulting in polyhydramnios. So these are the 2 complications of tracheoesophageal fistulae. I talked about one is the pneumonitis, the other is the polyhydramnios. Now let's come to the investigation that you could do in the tracheoesophageal fistulae. Over here in diagram A, you can see here the upper part of the esophagus, it is atretic, it is ending blindly. And let's look at B. B is showing us the radiograph of the tracheoesophageal fistula, and here the contrast radiograph is showing us the fistulous tract between the trachea and the esophagus. The arrow is pointing towards this fistulous tract. Also, if you just take a plain X-ray, a plain radiograph, you can see the blind esophageal tract over here. When you insert a nasogastric tube and then take a chest radiograph, you can see the coiling of the NG tube. And here you can see also the air in the distal gastrointestinal tract. This is also indicating the presence of the tracheoesophageal fistula. So what would be the scenario, the clinical scenario, if a baby is born with tracheoesophageal fistula and esophageal atresia? To give an example, here is a scenario which I've shared with you. So choking and continuous coughing were observed in a male neonate. There was an excessive amount of secreted mucus and saliva in his mouth. He also experienced considerable difficulty in breathing. The pediatrician was unable to pass a catheter through the esophagus into the stomach. So this is the scenario, this is the case presentation in case of tracheoesophageal fistula. I discussed the embryological basis with you. It's because of incomplete division of the foregut into trachea and esophagus. And the examination, as I showed you, you could do the contrast radiograph to confirm for this abnormality. And similarly, here is another scenario in which a neonate with esophageal atresia experienced respiratory distress with cyanosis shortly after birth. And the radiographs demonstrated air in the infant's stomach. So how did the air enter the stomach? We also talked about this, that there's a tracheoesophageal fistula. So the air has entered through that fistula into the stomach. And the other problem which might result in an infant with this fairly common type of birth defect, but like I told you, pneumonitis is a complication that can occur, lung infections can occur, right? Okay, so now we will discuss the other very important, commonly asked question. This appears in the examination often whenever we talk about lung development, whenever we talk about the pediatric congenital conditions. So we will discuss the infantile respiratory distress syndrome, which is abbreviated as IRDS. So this is an important topic, and the main things which you have to remember, the key points about this topic is that, first of all, let's start with that it was previously known as hyaline membrane disease, but now we commonly call it as IRDS. This is an acute lung disease caused by surfactant deficiency, which leads to the collapse of the alveoli and non-compliance of the lungs. And these alveoli, remember, they tend to collapse mainly during expiration. So what are the signs and symptoms of respiratory distress? There'll be shortness of breath and cyanosis, and all these symptoms are going to appear at the time of birth or shortly after birth. That is within a few hours, first 5 or 6 hours after birth. And then these symptoms, if they don't resolve, then they will escalate within the next 24 to 48 hours. This, remember, is a condition I told you which occurs due to surfactant deficiency. So it primarily occurs in those babies who are born premature, that is mainly before 32 weeks of gestation, when the surfactant levels are not sufficient to allow for fetus survival. Now, there are other predisposing factors to IRDS other than prematurity. The premature rupture of membranes, cesarean sections, asphyxia, perinatal asphyxia. These are different conditions which predispose to IRDS, and the incidence has seemed to be more in the male babies and also babies born to diabetic mothers. What would be the characteristic findings of IRDS on the chest radiograph? Now, this is something which you have to understand, and you have to relate with the abnormal deposition of the hyaline membranes. So what happens in respiratory distress syndrome within the lungs is that there is going to be abnormal deposition of an infiltrate. There's going to be hypoaeration of the lungs. You know, the lungs, they are hypoaerated, and meaning they're underinflated, and they also are going to the volume is going to decrease. So here you can see that causes the appearance of a bell-shaped thorax. Now, what do you mean by bell-shaped thorax? When the superior aperture is narrow and the inferior aperture is broad. This gives a bell-shaped thorax. Next, like I talked about the infiltrate, the deposition of the infiltrates within the lung parenchyma. This causes a granular appearance. If you look at this, you can see these are the uniformly distributed opacities throughout the lung parenchyma, which is visible on the chest radiograph. And this is known as the ground glass appearance. Also, the air bronchograms are visible. Now, these arrows are pointing towards these air bronchograms. Now, when we talk about these air bronchograms, these are visible because of the deposition of the infiltrate on the walls of the larger air passages, whereas the air is present still within those air passages and the larger air passages. And this appearance is known as the air bronchograms. Now, in severe cases, the presence of these opacities is going to obscure the cardiac silhouette or the borders of the heart, and this is then known as the bilateral whiteout of the lungs. This appearance is known as bilateral whiteout. Fortunately, the treatment of IRDS is now available, and that is the administration of artificial pulmonary surfactant. Glucocorticoids are also administered to boost the production of the natural surfactant. And this has decreased the incidence of IRDS. In the end of this topic, I would like to summarize a few factors which are important for lung development. Since we were talking about lung development, I would like to summarize these factors which are necessary for the development of the lungs. Now, the first one, we can say is the adequate thoracic space of lung growth. Of course, the lungs need a growth area to expand within. And then the adequate quantity of amniotic fluid. This is essential also for the lung development. Fetal breathing movements. These are the movements which begin before birth, and they also have a role in lung development. Adequate quantity of surfactant, we talked about that before. It is essential for normal lung development, as well as the well-established pulmonary and systemic circulations. And of course, the development of the nervous system is also essential for normal lung development. So this concludes with today's discussion on the development of the respiratory system, in which we covered all the essential aspects from the formation of respiratory diverticulum and then its division, further the bronchial tree branching, and we also talked about the stages of lung maturation and the factors involved in normal lung development. And if you like today's video lecture on the lung development, kindly like and subscribe to my YouTube channel, which is AnatomyMentor. You can do that by simply clicking on my picture, which is going to pop up at the end of this video. And you can also follow my Facebook page, which is also by the name of AnatomyMentor on Facebook. So hope this was helpful for you. Thank you and take care and stay blessed. Allah Hafiz.